evening, everyone. Welcome to the fifth seminar of SarvArogya, the Rice Foundation. We are heartily welcome you all to our webinar. I would like to heartily welcome Dr. Prairna Koul for this session, and I would like to call Ms. the Project Director of SarvArogya, the Rice Foundation, Sneha ma'am, for the program introduction. Over to you, ma'am.
Thank you, Shivam. So, good evening, everyone. I'm delighted to welcome you all to the fifth webinar of SarvArogya. Also, I would like to extend my sincere gratitude to Prasad Institute of Medical Sciences for supporting this initiative. First of all, on behalf of the entire The Rice family, I welcome Dr. Prairna Koul, ma'am, who is presently the health officer at the United Nations Children's Fund. We are truly honored to have you, ma'am, with us to share your insights on adolescent health, emerging trend, key challenges, and pathways for action. But before Dr. Prairna, ma'am, expresses her thought, let's set the context right. Why this SarvArogya webinar? See, now India today has the largest adolescent population in the world. As per the national estimates, roughly one in every five adolescent in the world of the age 10 years to 19 years lives in India. Now, this presents a huge demographic opportunity. But is India doing enough to ensure that the adolescent population living here becomes productive? See, even today, after more than 79 years of independence, the country continues to report some of the world's highest level of stunting, wasting, anemia, and undernutrition. These numbers, I tell you, are deeply concerning. And it's not just malnutrition. There is also a rise of obesity, diabetes, hypertension, and other lifestyle diseases among these young people. The challenge does not end here. Substance abuse, be it in terms of drugs or alcohol, is increasing. Mental health issues are becoming more visible. Influence of social media is increasing, we all know. In fact, the economic survey this year, for the first time, it formally flagged the excessive screen time and digital addiction as a major public health concern. Today, adolescents are growing up in an environment where the food is adulterated, the air is polluted, and the physical activity has declined. There is this social media which is shaping their habits, their aspirations, their food choices, their mental well being, and whatnot. So, why is investing in adolescence so critical? The answer lies in both biology and economics. Adolescence is not just a transition from childhood to adulthood. In fact, it is the second most important window of growth and development after the first 1,000 days of life. In this period, half of the adult skeletal mass is developed, over up to one fourth of the height is achieved, and the brain has also significantly matured. An unhealthy adolescent is likely to become an unhealthy adult. Say, for example, an anemic adolescent girl today is likely to become an anemic mother tomorrow. An anemic mother will deliver a weak child, and this continues the intergenerational cycle of malnutrition. Now we come to an even more important question. How do we invest in this age group? How do we ensure that the interventions made actually reach these adolescents? See, we need to understand adolescents neither have the awareness nor do they have the agency to make a informed health decision, as they are majorly home based. Their health is largely determined by the ecosystem around them, be it their parents, their schools, or the neighborhood. And this is precisely why improving the adolescent health cannot be achieved by just distributing iron tablets or running an isolated awareness campaign. to invest in adolescent health, we need to invest in the ecosystem around, be it through educating parents about the health requirement, or schools becoming the centers of the health education, or communities coming together to handle issues like early marriages. Ultimately, adolescent health is not just a health concern. It is linked with education, it is linked with nutrition, gender equality, social protection, and economic development. So, the question before us is, how do we create an ecosystem where every adolescent has the right to nutrition? He or she has the right to information, right to quality healthcare, and the opportunity to make informed choices with respect to his health. And this is precisely the main discussion we aim to start with through this webinar. Shivam, over to you.
Thank you, ma'am. Now I would like to request Sneha, ma'am, to share the brief profile of our chief guest today. Over to you, ma'am.
So, Dr. Prairna Koul is a medico turned public health professional with masters in public health from Tata Institute of Social Sciences, Mumbai, with reproductive, maternal, newborn, child, and adolescent health at her heart. She has a working experience of over 12 years in various capacities at the regional, state, and the national level. During the tenure, she has also contributed in various organizations, say SEWA, Care India, PCI, etc. Ma'am has been a critical contributor in shaping the adolescent health program in India with the Ministry of Health and Family Welfare, including the school health and wellness program. Thereafter, she also led to the establishment of health and nutrition practice in Microsave Consulting as a manager. Currently, Dr. Prairna ma'am is leading the RCH portfolio of the UNICEF Bihar office as a health officer. It's truly an honor to have you, ma'am, with us today. Over to you, ma'am.
Thank you so much, Sneha. And what you said is actually music to my ears. A lot of people do not talk about adolescent health, but you approaching me and very specifically asking me to speak on adolescent health reflects how you look at it. And I'm really glad that some young organizations like you and somebody like you is talking and advocating for adolescent health in India and the need to invest is right now. So I'll be talking about a bit of what you have already said, some bit of data. But I would also like to tell you what government of India is already doing. We have programs. It's not that we have not been able to do anything about it. We are doing something about it. But yes, as you said, that just distribution of iron folic acid tablets or doing the awareness programs would not reach the goal where we intend to reach with these programs. So I am Prairna, and I started my career in Bihar as Sneha introduced, and Bihar is where I am right now. I see some people online, and it would be good to have your cameras on so that I know that I'm not speaking to a screen. It's good to see faces and smiles on your lovely faces. Okay. I would now be sharing a presentation. Just let me know when that is visible. You'll have to bear with me, guys, because is that visible?
Yes, it is. It is visible.
Okay. So, this is what I think. This is still not in the... It's visible now?
Yes.
Okay, perfect. So first of all, when I talk about UNICEF, and that's where I come from, for UN, the definition that Sneha said, 10 to 19 years of age. So that is the UN definition of adolescents. But when in UN we talk about children, and especially in UNICEF when we talk about children, we consider 0 to 18 years of age as a child, because we believe that that's the age group. They are not yet adults. That's where we come in. Guys, I will not be able to see any chats because my screen is full screen presentation. So just park your suggestions, questions, anything that you want to ask in the chat, and then we can come to that later. Now, this is what global data. So if we talk about that's what was HIV. That is what the data speaks about global HIV. And if you talk about other sexually transmitted infections, about 7,000 per 1 lakh population in adolescents. That's the highest among 10 to 14 years of age. That is what is the incidence of STIs. If you talk about the communicable diseases, top 10 causes of death, and I will talk about the causes of death and morbidity and mortality in adolescents later. But those are one of the most major contributing populations across the world. And if you talk about non-communicable diseases, most top 10 causes of morbidity among adolescents are NCDs, primarily mental health related, okay, which includes anxiety disorders, childhood behavior disorders, depressions. And when we specifically talk about the global prevalence of mental health disorders, it's estimated to be about 13.5 for ages 10 to 14, and even more to a tune of 15% in the ages of 15 to 19. So that is, more than 1 in every 10 adolescents is suffering from these. Now, there are unintentional injuries and violence also, where there are sexual and reproductive challenges. There are social issues like child marriage, the adolescent birth rate. The adolescents giving to children even before they are turning 18. There's complications that come with pregnancy and childbirth in adolescents. There's gender-based violence, and in some parts of the world, and now it's actually becoming a global phenomenon, which is female genital mutilation. So earlier it used to be restricted in African countries and those parts of the world, but with migration, it's going on to become a global problem. Now, if you talk about the main causes of adolescent mortality, why are adolescents dying? And you'll be surprised to know it's not a disease that is killing them primarily. The top cause of death in 10 to 15 years of age in males is road injury, and for females it is viral diseases. When you shift this to 15 to 18 years of age, road injury still remains the first cause of death in the male, and TB and maternal conditions become the leading causes of death in case of females. That the etymology of it is. When you think that it's a healthy population, there are no diseases, that's the general perception that they're young people, they will not be affected by any diseases. So that is where that perception comes in, that no, road traffic accidents, because they tend to take, there's risk-taking behavior. And then for females, pregnancy, the conception onset is early, and that's why the maternal conditions become major. And if you look at the causes of morbidity, or if you look at the top 10 global risk factors associated with adolescents, DALYs, that is disability adjusted life years, by sex and age, iron deficiency remains the top reason for males as well as females in 10 to 14 years of age. And when you look at 15 to 19 years of age, for males, there are occupational injuries, which points to a direction where the males in this age group are already out and trying to earn their livelihood, when at a time they should be inside the schools, inside the colleges. And for females, it is iron deficiency, as Neha said.
So essentially, that is the reason why iron folic acid is such a big deal, because iron deficiency still remains one of the top morbidities amongst adolescents, including boys and girls, more in girls, but then it still is there. Now, if you look at the Indian adolescent health scenario, where about 22% of the total population is adolescent. Okay, and out of that, 12% is 10 to 14 years, and 10 is about 15 to 19. And if you look at NFHS data or the NCRB data or Yale survey or National Mental Health Survey, so there are a lot of, there's a picture, and I would have loved to show you the slide, but I will be sharing this slide. So essentially, 23% of women get married before the age of 18. And we have a law since ages that says that, marriage below 18 is illegal, but it's still happening. 6.8% women have teenage pregnancies. They are getting pregnant before 19 years of age. The comprehensive knowledge of HIV/AIDS, which we think is a very common knowledge and everybody would know about it, only 21.6% of females and 30% of males have that comprehensive knowledge. So essentially, about 70 to 80% of the people do not have comprehensive knowledge on HIV/AIDS. Adolescent fertility rate is 43%. Yes, I see the reactions. So, 22% of women aged about 15 to 20, 24 years of age do not use any hygienic methods during menstruation. 22% do not use it. If you talk about nutrition problems, and Sneha has shed some light on it initially, but then 60% of girls are anemic in India in this age group. That is still a huge, huge, huge number. On the contrary, only 31% boys are anemic. Okay, and more than two-thirds of the adolescent population, which is about 11 to 17 years of age, are physically inactive. And we define physical activity by any half an hour, and you can read those definitions in NFHS, but half an hour of physical activity. Now, talk about substance abuse. 7% of adolescents have used or experimented with tobacco, and the mean age of initiation of tobacco was 14 years in adolescent. 14 years is nothing. Like, you would look around you and see a child who is 13 or 14 years of age. You would be treating them as a kid, right? But then they have already started tobacco. And if you talk about alcohol, the age is even lower. The mean age of initiation of alcohol in India is 13 years of age. People are already experimenting, initiating alcohol use. Now, if to talk about accidental deaths, which I said that road traffic accidents, about 5% of deaths are in this age group. Suicidal deaths, about 1.3%, and 7% of suicides, they are increasing at a rate of 5 to 10% annually. That is where the suicidal deaths in this age group are. 14% of young adults exhibit some signs of mental health disorders, and 30% of ever married women have experienced spousal violence. So the numbers are huge, right? Those are the numbers. And then, as the ex-director of ICMR, Dr. Soumya Swaminathan, used to say, that these are all numbers, right? We say them very casually, but then each of these numbers has a face, a family behind it. So that is what we are, talking about. Now, to top on all of this, the pandemic actually affected the adolescent very disproportionately. There was disrupted education, there was loss of safety nets, there was increased risk of violence, the mental health challenges were more, there was poor sexual and reproductive health, decreased access to essential services, including immunization, reproductive health services. There was much more decline in the physical activity, and then, of course, there were environmental issues, of climate change, which are associated with adverse health and well-being outcomes in adolescents. So that is what the pandemic did. But then there are, beyond all that, behind all that, there are health inequities in India which are affecting the adolescent health and wellness. If you look at the NFHS, it reveals that the disparity in literacy rates, which is 70%, 71% of women and 84% of men being literate. Education level directly impacts the health awareness, healthcare access, seeking behavior, and nutrition. Now, talk about gender. Discrimination about females begins at birth, evident from the sex ratio at birth, which was 929 females per thousand males. And if you talk about the disparities, they still persist throughout the life, affecting the expectancy, nutrition, which is exacerbated by the male child preference and sex selective practices. And gender discrimination does contribute to increased anemia of women in the reproductive age group. Talk about the economic status. Out of pocket expenditure disproportionately affects the poor and low income. And then the adolescents who are coming from that background would be affected more, would be more vulnerable as compared to ones coming from the richer percentiles. Anmol, yes, you'll not be able to see my video because I've switched it off for my cranky internet. It's not liking me right now. But yeah, I will. You can see my face, and then I will be sharing the, uh, you know, presentation later with you. Uh, Talk about sanitation. About 70% of the population uses improved sanitation facilities. They are still and rest are still exposed to, especially the women, they are exposed to reproductive infections and violence, which in turn would affect their fertility, would affect their reproductive health in the long run. If again the rural urban divide does exacerbate these inequalities, vulnerabilities for the especially for the people coming from the lower castes, tribal identity, left wing extremism, they are all the things that just make these vulnerabilities more severe. And then, of course, there is disaster proneness. For an area which is flooded, for an area which is drought prone. All these effects will be more as compared to the normal adolescents. Now, as Sneha has already talked about why are we working with adolescents? That's what data speaks. Okay, and now let me come to the soft parts of it. Adolescent, as she said, is a period of rapid physical change. It is also a period of vulnerabilities. If there are no safety nets, there is lack of safe spaces, or at least the adolescents feel so. And then the risky behaviors are there. Now, this is a age group where if you invest, it would bring the triple benefits. So the adolescents would be healthy now, they would turn into the healthy adults in future, and then they would bear a generation which is healthier. So right now, investing in adolescent at any point of time would give you a triple benefit, and that is what WHO says. Now, recognizing all that, India is working on two specific programs. So, India is also a country which is one of the first, and I'm not sure if there is any other, to have a dedicated vertical adolescent health program. With the scale of adolescents that India has, RKSK, Rashtriya Kishore Swasthya Karyakram, is one of the first globally to take care, or it's one of the first public health programs that runs with government budget through government platforms to take care of the adolescents. And when we talk about the thematic areas of RKSK, it tries to address six major thematic areas. So whatever data we looked at are essentially pointing towards six areas: SRH, sexual reproductive health; nutrition; non-communicable diseases; substance misuse; prevention of injuries and violence; and mental health. So those are the six areas where the National Adolescent Health Program of India is uh, trying to work on. Now, this was launched in 2018, okay, and then I will share the slide with you where it was not that it was for the first time that we were talking about the adolescents in India, but the earlier health policies, the 5-year plans, starting from the Bore Committee, was talking about sexual reproductive health, majorly of the adolescents or the young people. And then as we got the evidence later, it was realized that SRH is not the only problem that adolescents are facing, and that is when we added all those five other thematic areas in the national plan. Now, how does it do it? Yes, it tries to address these six areas, but how does it do it? So there are three approaches. First is facility-based approach. So facility is a hospital-based approach where Government of India tried to establish adolescent-friendly health clinics. Then it also tried to train the doctors, nurses, counselors specifically on the adolescent counseling skills, because working with adolescents is very different than working with the children or adult population. So that was recognized, and a specific package was developed for training of these people who would be talking to the adolescents. That is first vertical of where the interventions go. Second is in the schools. As Neha said, the weekly iron folic acid. It is in the schools, it is in the Anganwadi centers. There is convergence with the RBSK teams, and then there is also menstrual hygiene scheme where Government of India does give free sanitary napkins to the out of school adolescent girls to start with, because the assumption is that the ones who are going to school, yes, it is not a very right assumption, but then because based on the budget, Government of India always does programs in a very phased manner. So the more vulnerable get the budget resources investments earlier as compared to the others. And it was assumed that the out of school girls would have lesser access to information and hygiene. So that is where the Government of India came in to fill that gap. And the assumption was the girls who are going to school would have an agency or the resources or the support from their families and communities to use and have access to the hygienic sources of hygienic methods of menstrual management. Now that's the school becomes the second platform. Now the third platform is community. Now under RKSK, Government of India also planned to have peer educators. And the rationale behind it was in the communities. And the rationale behind it was that if you remember your own adolescence, you would not go to an adult for any information. You would not talk to your parents very comfortably. You would not talk to your teachers, doctors, anybody. So, who is your first source of information? Who are you most comfortable with? Is your community, is your peers, right? Your friends. That is what becomes the first source of information for most of the adults. And recognizing that, Government of India made these peer educators who would be somebody like Asha, who would be adolescents in your own area, who would know you, and who would be trained a bit more as compared to you on all these six thematic areas. And then you become the ones to connect the adolescents to the hospitals, schools, or any other public health facilities needed. Then there were community events designed called Adolescent Health Days, Adolescent Friendly Club meetings, and Government of India has also given funds for each of them in the, you know, program implementation plans of the states, and you can go through them to see what all is covered. And similarly, as was covered in the school, the community also tries to cover the mental health, the menstrual hygiene scheme, as well as the iron folic acid. Now, if you look at the, since about 8 years of about a decade of implementation of this, what are the issues and challenges under RKSK? So, one of the major problems that adolescent health and behavior would always face is inadequate data. If you look at the research around you, there would be a lot of research, say, on immunization, on reproductive child health, or mental health, on any diseases. But because adolescents do not have a disease, what they bear right now or what they suffer right now is going to be detrimental in the long run. It does not kill them usually, right? So that is why the investments there are lesser in terms of research, also in terms of program, also. And because of that, there's lack of perceived benefit of adolescent health because they do not see the results tomorrow, right? If you make an adolescent aware on, say, substance abuse or gender based violence, you'll not see the result tomorrow. You immunize the child today, you will see the result tomorrow, right? Tomorrow onwards or the week later, you would be able to see the child would not die of, say, tuberculosis now. But you cannot say that for adolescents. And that is where the gap is. Adolescent health also has linkages. It's not just one sector, as Neha very aptly in the initial address said, that all the sectors and every sector has to come together, and this has to be a multi-sectoral action plan, without which the desired outcome will not be possible. And because of all this, the investments in the adolescents have a very long latent period. You'll be able to see the results later, and then that's why they don't like we all need quick results, right? We all need quick gratification. So adolescent health does not give you that. Adolescent is lambi race ka goda to what I call it. All right. Um, so that's essentially about the adolescent health programming in India. And the other program that was mentioned also in my intro was the Ayushman Bharat School Health and Wellness Program. That's a comparatively recent program. I'm so sorry. I think I mixed the timelines. The adolescent health, school health and wellness program is 2018 onwards. RKSK has been there since 2008 in pilot stages, and then the guidelines were also revised in about 2014, the revised guidelines. So, coming on to the school health and wellness program. So, while Government of India and across India we were implementing the RKSK, the government realized that an adolescent may not come to a hospital and share its problems with the doctor. They may also not share some things with the peers. And all the problems that we were trying to address in RKSK were the treatment aspects of it. There was no promotion or health, health promotion or disease prevention aspect of it. And that is why School Health and Wellness Program was launched. So it's a flagship program of Government India, which was jointly developed by Ministry of Health and Education and NCRT being the developer of the curriculum. It has 11 themes. So see, that's how the government also evolved. For the people who question that enough has not been done, I would always say that Government of India has beautiful guidelines. It's just the implementation and the scale that we operate on. It's very difficult to monitor and handhold and train, and sometimes we lose a lot of things in the transit. So, having said that, we had 11 themes. So, starting from the six RKSK themes, we went on to identify 11 themes, and it had everything and anything that an adolescent would be affected of. So, it has cybersecurity, it has civic sense, it has road safety, it has substance abuse, it has climate change. So, all those areas, and you can all go through these guidelines. They are very readily available. Just type the name of the program and you will get that. And then there's official NHM website of Government of India where you will get all this material. Now, the idea was to train the teachers who would train the students. So, students are a captive audience, right? So, you would agree with me that if a child learns hand washing in the school, he or she will very excitedly come back to home and show that hand washing to everybody in the family without even asking, right? So that is what we were counting on. We were counting on the fact that we will train and educate these children, and they will become the change agents back in their families, back in their communities. But first of all, they will have that informed uh, choice option available with them, that they are making whatever choices, say, for example, of having an activity, physical activity, eating anything, reading anything, using or not using the screen, basis all this information. And then it talked about growing up healthy, emotional well being, how are the interpersonal relationships, values and responsible citizenships, gender equality, nutrition, promotion of healthy lifestyle, HIV prevention, and promotion of safe use of internet and gadgets. So those were the 11 themes of it. And under that, Government of India then in phased manner took it to all the states. It is a part of curriculum of Government of India. NCRT, it was led, the curriculum design was led by NCRT, and it has gone into the curriculum of the schools. So it is literally a subject that is being taught across government schools in India. It has not been saturated to 100%, but then the plan is to take it in phases. Some states like say Andhra Pradesh or MP have really picked this up, but state they have been also phased implementation in terms of the number of states doing in, because the budgets were allocated accordingly. And yes, those are the two major programs. But to kind of summarize it all, I would just say that India's unique window of opportunity is adolescents. We talk about demographic dividends, but as Sneha said, it is not really a demographic dividend if you're not able to use it. And that is our opportunity. Another 5 years, another 10 years, we will not have this, but this is the time. And I can give you a list of all these documents that you can refer. So cost of inaction is huge, so you need to act now, you need to act right now. That is it, guys, in terms of the the presentation. I will share the presentation with you. I would have loved for you to see it parallelly, but then my internet did not want it. So yeah, that is it from my side. If there are any questions, any suggestions, any comments, I would be happy to engage.
Any questions? Um, People who have any questions, please go ahead and ask. Nikhil?
Yes. Hi, ma'am. Am I audible?
Yes, you are audible. Go ahead.
Yeah. Good evening, ma'am. Ma'am, my question is that you specifically mentioned that you are positioned in the state of Bihar, and if you see the Bihar is like a very not performing that much good across all the different health indicators, and in the state of Bihar itself, like intra-state disparity is too much high. There are eastern pockets in Bihar. So my question is, what are the main specific challenges that you think are there, which makes Bihar very difficult for a state to get health or get things correct?
Thank you, Nikhil. That's actually a very insightful question. And, and as I was talking to Sneha, she tells me that a lot of you are from the medical background. And, when we talk in text, when we read our textbooks, we talk about social determinants of health, right? And that is the answer to your question. So, health per se is not just the health. What is the literacy rate of Bihar? What is the school enrollment rate of Bihar? How is the temperature? What are the floods doing to Bihar? Right? So, for example, in an area where the health had actually improved, the education had improved, or anything had improved, a flood comes and it is all gone back to zero. Okay, so there are those emergencies. There are health emergencies like Japanese encephalitis, which are very local to Bihar, which are not in any other areas. A lot of population, which is migrant from Bihar to other areas. And that is one primary reason of increased HIV incidence in Bihar. So, those local contexts of gender inequality is also, something that does contribute to the outcomes of whatever you do. And then there is, uh, see, India, Bihar is to India what India is to globe, right? So people say that if India changes, the globe changes. And same is true with Bihar in terms of the population, in terms of the geographical variations, in terms of the, uh, it's 10 different states in one state. Right. So how you really cannot take one size fits it all to Bihar. And what I have personally experienced is that it's not difficult to make change in Bihar, but what is difficult is to sustain it. So we right now have about say 20, 30 development partners also supporting the government of Bihar, including UN. Right? So change is there, change happens. But how do you sustain it? Tomorrow, if I'm not there, how do you do it? So is the capacity of the system strengthened to a level where they are able to sustain the gains, uh, you know, gains because of the interventions, because of the overall development and the social development per se. See, now you look at a state like Gujarat where uh, a riverfront was developed, right? And it is a UNESCO heritage site. Now, on the contrary, if you look at Bihar, every single district has an archaeological monument. But how many of us know about it? And that those are all the indirect impacts, not just on the health, but overall economy of the state. They are not able to, I would, go on to say, sell, for the lack of a better word, the heritage, right? That is where Patliputra was. So okay, I'm digressing a bit from the question, but then essentially, what I'm telling you is that the economic, the political will, right? That's a very critical thing. And the overall development, not just for health, but overall social development of a state will always reflect. So it's not that somebody was working on health and that is why NFHS changed, that is why nutrition status improved. No. So nutrition status of the children is directly proportional to education of their mother. Or if the mother is working, it will directly improve the nutrition status of the child. So there are those confounding factors which you may not see directly, but then indirectly that will all impact the outcomes that you are getting. Yeah.
Yeah, thank you, ma'am.
Pleasure, Nikhil.
Prateek, please go ahead.
Thanks for your talk. It was really an enlightening one. So, ma'am, I wanted to ask that could you expose us to a few of the grassroots initiatives which have really worked across the country? So, at the micro level, if there are some initiatives at the village level or at the block level, if you can tell us some of that.
You mean in adolescent health?
Yes, ma'am.
Okay. So, in adolescent health, I'll tell you, um, there's this case of MP. Okay. So what MP State did was, when I was talking to you about the peer educators, so Government of India said that you identify these peer educators like you identify ASHA, train them, they will do these meetings in their own areas, and then you can, they will refer these adolescents to the public health facilities or the hospitals or doctors. And Government of India also gave an option on the, and this was included in the revision of 2018 guidelines, that you can do this through an NGO. Now, what MP has been very smart, and MP has been very, I would say, productive in terms of the outcomes of this peer educator initiative, to create a kind of competition among the peer educators of different districts. They outsourced this whole initiative to 3 NGOs across the state. So 3 NGOs were taking care of this peer educator initiative in 3 different regions. So state was divided in 3 regions, and then three were taking care of it. Now this NGO, see, the government, the funds that, or the expenditure that government was doing was same, right? But they were all local NGOs, no big shot NGOs. They were very local NGOs who had good presence in the local areas, and then government would monitor them. Okay, so government did not directly go into the conventional giving the money to district giving money to the block giving money to the village, and then they spending it, giving the expenditure. Bhagwan jane hua ya nahi hua, right? Now this was an NGO. It was because it was through an NGO. NGO also had some, credibility to show in terms of that they have been associated with this government program. That was also winning them credits or visibility, right? So it was a win-win for both. They competed against, amongst themselves who was doing it the best. And you could actually see, you go to any village or any block of MP, you will see peer educators in their full bloom. I've personally gone there. I have seen girls of, say, 9 years, 10 years, going to the families, getting to know of a child marriage happening, going and standing in front of the whole village and saying, no, we will not do it. That is the kind of
That's very
agency and
interesting, ma'am.
empower. Yeah.
Yes.
So that's the kind of agency and empowerment we are saying. And see, I will also tell you this. You just need to channelize the adolescents. Adolescents are full of energy. They don't know what to do with that energy. So give them something and they will give you, and I believe this for communities also. Give them something, they have their own intelligence, which we have stopped to trust. And we are building these models and frameworks and everything. And I will tell you this, that if a hospital does not have an examination corner for a pregnant woman in a VHSND site, a community can come together. One will get a bench, second will get a sari, second will get a rod, third person will get a rod, and they will create an examination corner. But have you asked your communities for help? So while there's
Very true,
one
ma'am.
side of top-down approach, there's this bottoms-up approach also, and you need to explore both to be able to get the results.
Rightly
Yes,
said.
ma'am. Thank you, ma'am.
Any other questions?
Yes, ma'am, I have a question.
Yes, please go ahead.
Ma'am, as you mentioned that it is alarming that nearly two-thirds of the adolescents in India are physically inactive. But in a world dominated by the screen and the academic pressure currently building in the schools or the colleges, how can the schools and communities practically encourage teenagers or the adolescents to get moving through these hurdles?
How can or how are they doing?
Uh, how can what they can suggest, or what they can do best for the adolescent?
So, see, I will tell you this, and it holds true for everything. We used to do this quality assurance workshop in the healthcare quality improvement. And we say in that if a person is making a mistake, it's not that person making the mistake. The system is designed for that person to make a mistake. Okay. Now, for example, if you and me today want to, we are very after this workshop or after seeing a reel or after hearing about a celebrity dying of cardiac arrest, we are very inspired to work out, right? And we go out and we do not have a place to work out. And that is where the system comes in. Is the ecosystem giving them enough spaces, enough alternatives to the screen time? So in school health and wellness program, where we are talking about the screen time, we are also talking, there's actually an activity which talks about screen time. And it's not enough to tell the children to be off screen, but we need to give them an alternative. What will they do in that time? Is that alternate activity interesting enough for them to shut off their phones for 5 minutes and do that? And that is where we need to think creatively and collectively, because it's not there right now.
Yes.
Right, ma'am. Ma'am, one last question from my side. Ma'am, as you talked about teenage pregnancies, yes, we all know. Suppose a 17-year-old gets pregnant, where should she go? She cannot go to the hospital. Neither can tell this to her parents. Ultimately, she visits an untrained medical professional or a quack in normal terms, and then something dangerous happens. How can a clinician or a doctor or a hospitals, what steps can they do so that doesn't become a hurdle for a girl or a pregnant teenager? Yes, ma'am.
So, Sneha, very, very, very critical question. And I think government is also confused to answer that question right now. And we have been struggling with this because there are two things. One is the right of that child to go to a health system and get the service. But then, because the person is not an adult, the it comes under the purview of POXO Act, okay, prevention of the child sexual abuse. So, the moment a child is pregnant and goes to a hospital, the hospital needs to inform the police. That's the legal mandate. But we also have to find ways to prevent it. And that's the only thing long-term solution. The moment the person is there, they need to inform the police. See, because of the whole question that you asked, a lot of the children are not even going to the hospitals because of the fear of their parents coming to know, the society coming to know. They are not going there, but they have to, they should. So ideally, the child needs to go to a hospital. The hospital cannot say no to it, provided it is also the hospital's responsibility to inform the police. But at the same time, not let that child go back without the stabilizing healthcare intervention. You cannot send them away right like that. But then all of this is in paper. What happens in practice is precisely what you said. And we have a long way to go to, for that stigma to end. Now, the recent Ketan Agarwal thing that is going on all over the internet, right? That girl fared saying no, and she chose to kill a person rather than saying no. It's not her fault. It's the society telling her, it's the conditioning telling her that, to know, to saying no has consequences. So, that destigmatization of getting uh, uh, healthcare intervention, even if you are below age, needs to be done. That's one aspect of it. Second aspect is prevention. And also, with prevention, we also believe that people are going to have sex. There's no, shying away from that. But can we make it safe? Is where our thought should be. are they able to access the contraceptive methods as any other adult? Is the way is the question is that is what we are asking. And the the school health and wellness program is designed also in a way that it's age appropriate. Something that you're teaching a sixth class girl or a boy is not something that you're teaching a 12th class person. So the person who is in 8th, 9th, 10th is also getting some information on the contraceptives, right? So yeah, it's actually, as you said, it's a mix of all the things coming together. There's no one answer to it, right? Because both the things are trying to safeguard. POXO is trying to safeguard that child. Health care facility is trying to safeguard the child, but they are not talking to each other.
Right. Thank you, ma'am. Now, any other question anyone has? Okay. Shivam, I would like you to summarize the session now.
Thank you, ma'am. So let's quickly go over the biggest lesson we learned today. As ma'am defined that adolescent health is a critical public health priority as it directly influences the health, productivity, and well-being of the future generations. As ma'am also talked about that iron deficiency remains a major contributor to morbidity in India. While poor menstrual hygiene, physical inactivity, which is affecting nearly two-thirds of the population, and rising suicide rate, which ma'am mentioned that 5 to 10% increase in the suicidal rates in adolescents. Ma'am also talked about that education plays a vital role in improving health awareness and nutrition, while social factors such as gender discrimination and rural and urban disparities continue to widen health inequalities. And ma'am also mentioned about the RKSK scheme. Under RKSK scheme, adolescent health intervention only focuses on 6 pillars, which is nutrition, sexual and reproductive health, mental health, substance misuse, injuries and violence, and prevention of non-communicable diseases. And these services are delivered through three approaches, which is hospital-based approach, school-based approach, and community-based interventions. Despite a well-being policy framework, major challenges remain, including inadequate investment, weak intersectoral linkages, limited utilization of adolescent-friendly health services, and the perception that hospitals are the only way for treatment rather than concerning them and focusing on the preventive care. Ultimately, the biggest challenge in implementation and scale is strengthening program delivery, improving coordination, and making adolescent-friendly services more accessible are essential to achieve better health outcomes for Indian adolescent health. That's all.
Thank you, Shivam. And with that, we take away from this webinar that focusing on adolescent health is the need of the hour to achieve our goal of the Vikasit Bharat. Thank you, ma'am. Thank you, everyone, for giving your time in this webinar.
Pleasure.
Thank
Pleasure.
you.
My
Thank
pleasure.
you. Thank you.
Thank you so much, guys. God bless
Thank
you.
you.
And I, believe that after this interaction, you all have become the advocates of adolescent health. So wherever you go, you talk about it because we only have 5 to 10 years, another decade of it, and we will not have this anymore. Okay. Take care. God bless all of you.
Thank you.
Thank you, ma'am.
Thank you. Thank you, everyone. Thank you, everyone, for joining. Thank you.